macules. It's associated with chromosome 17 and 22 translocation. Just remember type 1 is associated with chromosome 17 since 17 has a 1 in it. Type 2 is associated with chromosome 22 since it has 2's in it. And type 1 is associated with peripheral tumors. Type 2 is associated with central tumors. That's another way to separate them. So, neuromas and fibromas are the two tumors that you'll see in the syndrome. Notice it's buried in the name. So easy for you to remember. What syndromes have cafe-au-lait spots? There are two main ones you need to know. Neurofibromatosis is the one we just talked about, but there's a second one. The second one is called McCune-Albright syndrome. In McCune-Albright syndrome, you have cafe-au-lait spots associated with precocious puberty and fibrous bone tumors. What is precocious puberty? It means you're going through puberty at least 2 years ahead of time. That would be 8 for girls, 9 for boys. Second neurocutaneous syndrome, Sturge-Weber syndrome. Sturge-Weber usually has a large port wine stain on the forehead, the ophthalmic division of cranial 5. Now, port wine stain is a large but flat blood vessel tumor. So by knowing what this one is, you'll know also, or at least remember, that they also have other blood vessel tumors, usually in the retina and in the brain. And that's why space-occupying lesions can then cause seizures, it can cause hemiparesis, and of course mental retardation. So Sturge-Weber, port wine stain is the best clue for this one. And then the most hideous one that you ever want to run into is tuberous sclerosis. Tuberous sclerosis has ashen leaf spots, which will be described as hypopigmented macules on the skin. Remember, neurofibromatosis was hyper. These are hypo, so light patches. They have primary brain tumors, which we call tumors. So astrocytomas, gliomas, all of those will be part of this syndrome. But what makes this one the worst one is they have rhabdomyomas, benign, and rhabdomyosarcomas, highly malignant, of the heart. Having a cancer wrapped around your heart is never a good thing. And then they also have an increased incidence of renal cell carcinoma. So you have to perform surveillance in the kidney every year. More brain tumors and masses. The most common primary brain cancer, notice I use the word primary, is an astrocytoma grade 4, also known as glioblastoma multiforme. But the most common cancer overall of the brain is metastasis. For men, prostate first, lung second, colon cancer third. For women, breast cancer first, lung cancer second, colon cancer third. Metastasis is the most common brain cancer overall. So watch out for that word. Is it primary? Because if they don't use the word primary, you got to remember metastasis is the one. Now, if I were to ask you, give me 3 features of glioblastoma multiforme, most of you will start trying to remember what you read about glioblastoma multiforme. Don't do it that way. Folks, just think about glioblastoma multiforme is a cancer. And that means anything that refers to a cancer or applies to a cancer has to be a feature of this one. That means it produces a lot of angiogenin. That means it's vascular, causes hemorrhage, causes necrosis, is non-encapsulated, it adheres to other tissues nearby, it metastasizes, very aggressive. See what I mean? This way, you're accurate, but you're not trying to remember details you read a long time ago. And then in the stress of the moment, you forget the list. All right, moving on to pituitary. Pituitary, the most common tumor, is a pituitary adenoma. Remember, the prefix for everything that's glandular is adeno. So benign, adenoma. Malignant, adenocarcinoma. So for here in the pituitary, most common tumor, pituitary adenoma. There's different cell types in the pituitary, so you name it after them. 95% of cells in the pituitary are called chromophobes, and they are non-functional, which is why a non-functional chromophobic adenoma is the most common pituitary tumor. But then we have acidophils that produce prolactin and growth hormone. Those are usually pink colored. Then we have the basophils that produce the other hormones like ACTH, TSH, FSH, and LH. What's confusing is the most common functional tumor of the pituitary means the tumor produces a hormone is a prolactinoma. But a prolactinoma is not the most common pituitary tumor. What's even more confusing, all pituitary tumors lead to high prolactin. Why is that? If you remember, dopamine fibers from the hypothalamus come down to suppress prolactin at the pituitary. If I have a tumor in the pituitary, it's going to compress the fibers coming down from the hypothalamus, which means, therefore, prolactin gets released. Remember, prolactin is the only hormone in the pituitary that's under negative control at all times. So if you were cut off the fibers of dopamine, prolactin gets disinhibited. So watch out for this one. Pineal gland is the next one. The most common tumor, pineal adenoma or pinealoma. Clues for pinealoma, cranial nerve 6 runs close by, so you get cranial nerve 6 palsy, which means your eye will turn in. We call that esotropia. Or you see precocious puberty. Why is that? The pineal gland, remember, controls circadian rhythms. So without any control in circadian rhythms, puberty can happen at any time. That's how they're connected. Most common cancer of the pineal gland, adenocarcinoma. Very, very rare. What about posterior fossa tumors? These posterior fossa tumors are seen primarily in children. How will they present? Early morning vomiting. The reason for that is posterior fossa is right here in the back of your brain. So when you're laying down on a pillow, the tumor is laying down on the pillow with you. But when you stand up in the morning, that same tumor falls down on the floor of the fourth ventricle. And if you remember, that's where the chemotactic trigger zone is located, and suddenly you have vomiting every morning. Real common in children, posterior fossa tumors. CT scan does not get a good look at the posterior fossa, which is why we primarily do MRIs in children, because that way you get a good look at the posterior fossa and the anterior fossa at the same time. The two tumors you need to be aware of, medulloblastoma. This is really a cerebellar astrocytoma, but it's sitting on top of your medulla. And it's not always operable. Why? Because if you cut the medulla, the patient dies. So we're stuck with trying to cut out as much of it as we can and then apply radiation to it to try to shrink it as much as we can. The next one is a craniopharyngioma. Craniopharyngioma develops from Rathke's pouch. If you remember, Rathke's pouch is the anterior pituitary, which is from the top of the hard palate. So it develops in the hard palate, which is why you get this motor oil appearance in it, which is why you see calcifications in it, which is why it can damage the entire anterior pituitary and can even encroach and damage the posterior pituitary. So it can present a lot of different ways. So medulloblastoma and craniopharyngioma are the most common posterior fossa tumors, seen most commonly in children. All right, what about the mediastinum? So now we're coming down into the neck. The mediastinum, we're going to divide it into the anterior, middle, and posterior mediastinum to help us organize ourselves. So first, the posterior mediastinum. Mostly ganglia are left back there. Mostly ganglia. So the most common tumor, a neuroma. Most common cancer, neuroblastoma. Now, if you remember, neuroblastomas are very similar to pheochromocytomas, so I'm going to talk about both of them together. These cells are of neural crest origin, meaning what? They were born in the CNS, brainospinal cord, migrated out to the peripheral nervous system, and then stayed there. So for neuroblastoma, you have most of your ganglia in the abdomen. So that's why neuroblastoma is the most common abdominal mass in children, but not in the newborn period. The most common abdominal mass in a newborn is an enlarged bladder. because of bladder obstruction. Be careful. After that, then we say neuroblastoma is the most common abdominal mass. Classic clues: hips arrhythmia, dancing feet, opsoclonus, dancing eyes. Real easy to spot on an exam. This disease has the highest spontaneous regression rate of any tumor or cancer we know, 2%. You remember how I taught you the chance of chance alone is always 1 to 3%? So that means if you had been asked, what's the chance of any cancer disappearing by itself, folks? Remember, if you say 1 to 3%, you would have been right. You would have had this answer correct. Well, let's compare and contrast with pheochromocytoma. Pheochromocytoma is usually located in the adrenal gland, in the adrenal medulla specifically. We have the rule of tens that apply to it. Remember, if you have the rule of tens, that means the flip side, you have a rule of 90s as well. So 10% is seen in children, which means 90% are seen in adults. 10% are bilateral, which means 90% are unilateral. 10% are metastatic, which means 90% are contained in one organ. 10% are familial, which means 90% are sporadic mutations. And 10% are malignant, which means 90% are benign. How do we diagnose these two tumors? There's a surge of sympathetic outflow from these tumors into your body. So you will get paroxysmal, meaning it comes and goes. Paroxysmal palpitations, hypertension, headache, and diaphoresis. Anybody who gets intermittent surges of sympathetic tone, think pheochromocytoma first. Now, with pheochromocytoma and neuroblastoma, it's hard to differentiate the mass when it becomes malignant from when it's still benign. So for that reason, we remove all of them. So that's why they love asking that question, why do we remove these masses if they're benign? That's because we cannot tell when they've turned malignant. So what do you have to do? Treat them with medication until you take them to surgery and then remove the mass. How do we diagnose these masses? All right, you can check serum or urine VMA and metanephrines, or HVA, from dopamine breakdown. It turns out serum VMA and metanephrines is a little more sensitive than urine VMA and metanephrines. So on the test, you now know which one to pick. The other thing is, the other way to diagnose the disease, with medication. We can give you phentolamine, which is a short-acting alpha blocker. If your blood vessels were tightly constricted, and I give you an alpha blocker, immediately they release. And see that? Your blood pressure will drop quickly. Therefore, I can infer that you had significant sympathetic tone. So phentolamine is used to diagnose a pheochromocytoma, and then we use phenoxybenzamine to treat pheochromocytoma or neuroblastoma. Now, caution is you never use a pure beta blocker when you are treating something like a pheochromocytoma. Why is that? If you use a pure beta blocker, you're going to block the beta receptors. All the catecholamines will displace themselves and go to the alpha-1 receptor, causing more significant hypertension, which would potentially kill your patient. So that means when you're treating a patient, you can either use medication that blocks alpha receptors only, like phenoxybenzamine, and it's non-competitive. Remember, when a disease is deadly, you don't want competitive. So you can use an alpha blocker, like phenoxybenzamine, or you can use a drug that blocks alpha receptors and beta receptors, like labetalol and carvedilol. But never use a pure beta blocker to treat a pheo. Now, we go to the antiometastatinum now. In the antiometastatinum, we talk about the 4 T's. That's the thymus, the thyroid, T-cell leukemias and lymphomas, and then teratomas. Leukemias. If the lymphocytes are involved, folks, the majority are B lymphocytes. That means most leukemias are B-cell leukemias. There's only one leukemia that has a higher frequency. So the majority of leukemias, about 98% are B-cell leukemias. Maybe 2% are T-cell. But there's one with a higher number than that, about 25%, and that is hairy cell leukemia. Hairy cell leukemia got its name because the lymphocytes that are involved have all these hairy membrane projections coming out of them. It looks like hair, hence the name. B cell origin is still the most common. Most common is always most common, no matter what you're talking about. B cell origin here, though, is 75%. T cell origin is 25%. So it has 10 times the risk of B cell type or origin, but it's still not the most common. Fried egg appearance is how some literature will describe it. The best marker is the TRAP, tartrate-resistant acid phosphatase, a chemical that can identify these cells for you. So that's hairy cell leukemia. What about lymphomas? Again, the majority of lymphomas, 98% of them, are B-cell lymphomas. If they want a virus associated with it, remember we've talked about EBV. Always pick EBV, because EBV loves to infect B cells and cause mutations, hence the lymphoma. Only 2 lymphomas are pure in T-cell origin: mycosis fungoides and Sézary syndrome. Mycosis fungoides presents as a skin rash that just won't go away. And that's usually how they present it on most questions I've seen. The patient tries antifungal creams, doesn't work. Tries cortisone creams, it doesn't work. Tries all kinds of lotions, doesn't work. And finally, he goes to see the doctor. You have to biopsy it. And when you biopsy it, they always describe these T lymphocytes with indentations in their membrane. Or they use the word crenated. It's an identifying feature. When those same cells start metastasizing through the bloodstream, that's how we get Sézary syndrome. So Sézary syndrome is just a continuation of mycosis fungoides. Now you can tell from the term mycosis fungoides, they thought it was a fungal rash many years ago, but now we know exactly what it is. All right, another T, thymus. For the most common tumor, thymoma. That's the same thing as saying thymic adenoma. Thymomas are associated with almost every autoimmune disease except Graves' disease. Why is this? If you remember, your thymus is one of the 4 immunoprivileged sites in your body, meaning many of the cells inside your thymus are not declared to be any particular cell line, which means they can mutate and become any cell line that they want, and therefore your body then attacks them as foreign antigens because they don't belong there. So thymoma is associated with almost every autoimmune disease except Graves. So anytime they give you an autoimmune disease and they ask you for a tumor and you don't know of one, just say thymoma. Most common cancer, you would say adenocarcinoma, but this one's very rare. The last T, thyroid. Anytime somebody has a neck mass, swelling, if it's lateral, think of lymph nodes. Think of lymphomas. If it's midline anterior, think of thyroid. Now, a concept to teach you here. If you are asked what's the most common mass for any glandular organ, say cyst, because that's the answer almost every time, just so you don't have to keep rethinking it. So the most common mass for the thyroid gland is called a thyroglossal cyst. The most common tumor for the thyroid gland is called a follicular lymphoma. And the most common cancer for the thyroid gland is called papillary carcinoma of the thyroid. And if you remember, this is the one with one of the cancers with some homobodies that we discussed earlier. The good thing about papillary carcinoma of the thyroid is that distant metastasis is rare. So that means if you find it early and remove it, it's almost curative. The number 1 risk factor for thyroid cancer is irradiation to the neck. Previous radiation to the neck. Years ago, people would get radiation to the neck for acne before we realized what acne was. So the fallout from that practice was a lot of thyroid cancer. So if you got a thyroid mass, how do I approach it? Here's how you do it. You first feel it to see if it's cystic. If it's cystic, thyroglossal cyst is the most common. That would be midline anterior, moves up and down with your tongue, so when you swallow, you can tell. We always do an ultrasound next to verify that. And then we do a fine needle aspiration, because a fine needle aspiration is diagnostic and therapeutic at the same time. It'll make the cyst collapse. You can decide to take the thyroglossal cyst out later, but if you do, you always do a thyroid scan to find the thyroid tissue because you don't want to remove what little thyroid tissue they actually have. All right, what about on the right side? You see solid thyroid masses. Well, if you got a solid thyroid mass, the first thing we do is we do a thyroid scan. We want to know if that thyroid mass is active or not. If it's active, we call it a hot nodule. If it's non-active, we call it a cold nodule. The cold nodules are the bothersome ones because they have approximately 20% malignancy risk. If you have a hot nodule, you treat it like hyperthyroidism. No problem. So if you have a cold nodule and a history of previous radiation to the neck, that's the highest risk. And that's why they say do a lobectomy. If you cut out one lobe, the patient is still okay because they've got the other lobe and they're going to be fine. But if you have a hot nodule in your thyroid, treat it like hyperthyroidism, which means, remember, propranolol is the first drug. Then we give them methimazole or propylthiouracil. Methimazole we prefer before childbearing age and after menopause. It has the best penetration. But because it's so fat soluble, it also crosses the placenta to harm the fetus. So during the childbearing years, we prefer propylthiouracil, or PTU for short. Then you can use iodine 131 to destroy the thyroid and then put them on thyroid replacement from there. All right, now, if you have a cold nodule without a history of previous radiation, those are the ones we biopsy. And then the results of the biopsy will tell you what to do. So that's how you handle a cystic thyroid mass or a solid thyroid mass. Behind the thyroid, parathyroids. Remember, thyroidectomy is the #1 reason for parathyroid deficiency. All right, most common tumor of the parathyroids is called a parathyroid adenoma. This is the most common cause of isolated hypercalcemia in adults. Most common cancer of the parathyroid, adenocarcinoma. So here's where I thought I would review the MEN syndromes for you, because parathyroid adenoma can run with the MEN syndromes many times. So you have to check for them. Again, if you don't look, you won't know. All right, so MEN1, also known as Wermer syndrome, involves the 3 Ps, pituitary, pancreatic, and parathyroid masses. Multiple endocrine neoplasias. So benign tumors in the pituitary, pancreatic, and parathyroid. MEN2, sometimes called 2A, also known as Sippel syndrome. Medullary carcinoma of the thyroid, the one that's producing all the calcitonin. Pheochromocytoma, the one we just talked about. Plus or minus parathyroid adenoma. MEN2A or MEN2. MEN3 or 2B, depending on which literature you look at, is MEN2 plus neuroma or ganglion neuroma, usually on the mucosal surfaces, but without parathyroid adenomas. And then finally, they have a morphinoid habitus. That is the best clue to separate MEN2B. And if you remember, RET gene mutation is associated with MEN2 and 3, but not MEN1. So, quick review of MEN syndromes. Moving on, parafollicular gland. Parafollicular gland also behind the thyroid. Most common tumor, adenoma of the parafollicular gland. Most common cancer, medullary carcinoma of the thyroid, producing calcitonin. And of course, what does calcitonin do? It goes to the bone and inhibits the osteoclast. So hypocalcemia is going to be a problem. So parafollicular gland. Now we enter the middle mediastinum. In the middle mediastinum, you find the heart and the structures that relate to it. The heart has 3 layers, if you remember. Endocardium on the inside in contact with blood. Myocardium is the muscle around that. And then epicardium is the tissue on top of the myocardium. And then you have pericardium outside of all of that, encasing the heart for you. So, Let's start with endocardium. Most common tumor of the endocardium, myxoma, usually found in the left atrium. Usually you get a history of a diastolic plop, or you get a history of a female, remember estrogen connection, of a female who passes out only to recover a few seconds later. So if you got a myxoma on the wall of the left atrium, let's say, like my hand here, and this is your mitral valve, every now and then this mass goes right over the mitral valve. So you get a relative or functional mitral stenosis. And during diastole, you hear the plop. Every time the mitral valve opens, you hear a plop again. Those are classic clues for myxoma. Most common cancer of endocardium, angiosarcoma, which is very rare. What about the myocardium? Myocardium, if you remember, is related to the skeletal muscle. So the prefix we're going to be using is rhabdo. So that means most common tumor, rhabdomyoma. Most common cancer, rhabdomyosarcoma. Because remember, muscle is connective tissue. About the only time you hear about these is in the setting of tuberous sclerosis, as we discussed earlier. What about the epicardium? The epicardium is hardly ever involved in any neoplastic activity. What about pericardium? Pericardium, most common tumor would be a fibroma because it's made out of fibrous tissue. Most common cancer, metastasis. Don't forget that. One of the 6 places where metastasis is way more common than primary. Now we're into the lungs. In the lungs, most common mass in children, hamartoma. Remember, abnormal growth of normal tissue. Most common mass in adults, granulomas. Most common tumor, adenoma. Most common cancer, metastasis. Don't forget. Okay? But most common intrathoracic, that means Mets is not part of the picture anymore. Intrathoracic cancer is squamous cell carcinoma. And the most common primary lung cancer, then you use the term bronchogenic adenocarcinoma. So the term bronchogenic then tells me you're talking about lung parenchyma proper. Lung cancers then, primary lung cancers that is, we can separate them into 2 categories. Those that are central, along the midline. So they use words like perihilar mass. See? Something that obstructs your bronchus. Or peripheral masses. Then I know which ones they want. So central, think of the word central. That hissing sound reminds me of squamous cell carcinoma, small cell carcinoma, central. So squamous cell carcinoma is more common. It produces a PTH-related peptide. That means a protein that works just like your PTH, but it's not your PTH. So the patient's actual PTH will be suppressed, but they'll have very high PTH-related peptide, which means they're going to have high calcium and high and low phosphorus, because remember again, PTH stimulates osteoclastic activity. So whenever you have small cell carcinoma, then you have other hormones. So hypercalcemia is your clue for squamous cell carcinoma. And then for small cell carcinoma, Cushing's disease is the most common one you're going to see, probably 90% of the time. SIADH is what's seen 5% of the time. Occasionally, PTH and TSH are also seen. But Cushing's disease. So this one, because it's coming from the small cell carcinoma, if you remember, low-dose dexamethasone suppression test will not suppress. High-dose dexamethasone suppression test also will not suppress. But your ACTH level will be high. That's how you know it's lung cancer. What about the cancers that are peripheral? Bronchogenic adenocarcinoma and bronchoalveolar adenocarcinoma are in the periphery. Remember, the alveolus can only be peripheral. So because they're both in the periphery, they tend to cause collapse of alveoli out there. So a lot of times they present as a pneumonia. That means a pneumonic infiltrate. With treatment, though, it doesn't go away. That's when you get suspicious. And then you do a CT scan and you find that there's a mass underneath that infiltrate. Bronchoalveolar adenocarcinoma is the only lung cancer, primary lung cancer, not related to smoking. Very important to know. Bronchogenic adenocarcinoma and bronchoalveolar adenocarcinoma. What about risk factors for lung cancer? Number one risk factor for lung cancer, primary smoking. Second, radon. Third, secondhand smoke. Fourth, the pneumoconioses. With smoking, risk increases with duration and amount of cigarettes a person smokes. That means the longer they've been smoking and the more cigarettes they've been smoking, the greater risk for lung cancer. In secondhand smoke, that smoke that comes off the tip of the cigarette is called side stream smoke. That one has higher risk because it has not gone through the filter. Versus mainstream smoke, the one somebody rudely blows in your face, but they dragged it through the filter already, it has a slightly lower risk for lung cancer. And then pneumoconioses is work-related exposures. Almost all of them increase your risk for lung cancer except anthracosis. And asbestosis has the highest risk. So if we look at pneumoconioses, most of them they won't ask you about. Because if you say bird breeder's lung, well, you already told me what this guy does. Silo worker's lung, come on, those are too easy because they have to describe it that way. The 5 that show up on the exam all the time. Anthracosis has the lowest risk for lung cancer. That's coal miner's lung. When they factored out the smokers out of the group, there was no more risk for lung cancer remaining. Asbestosis, folks, has the highest risk for lung cancer. If you're a smoker and you've been exposed to asbestos, your risk is about 40 times that of the general population. But what they do on the exam, folks, is hint at it with what work the person does. So for asbestosis, shipyard worker has the highest risk. Shipyards of America are over 100 years old and they've never been rebuilt. So there's asbestos in the pipes and the roofs all over the place. Roofers, this is from old shingles. Pipe fitters, plumbers, because old pipes used to be lined with asbestos. Insulation removers. Old insulation used to have asbestos in it. A brake mechanic, because old brakes on the earlier cars, like in the 40s and 50s, had asbestos in their brakes. So they hint at it with the work the person does. What about silicosis? It usually is a sandblaster or glass blower. Sandblaster, like working on a highway, or glass blower, silicosis. Bisonosis, from cotton fibers. Somebody who works in a cotton factory or works on a farm picking cotton. Beryliosis. Beryllium is a metal, and these are the welders who put together televisions and radios. Now, if you remember, silicosis predisposes you to tuberculosis. Silicosis, primarily in the upper lobes.